Well, who doesn't love Journey? Let's not stop believing. Hello, everyone, and welcome to our 2023 ResearchCon closing keynote. My name is Sigrid Ladoris, one of this year's co-chairs, with Amy LaQuant and Dr. Jay Freeman. I can't believe how quickly the past 2 nights went. We're so grateful that you were able to join us to learn the latest in research, in clinical care, and connect with others through shared experiences.
Before we jump into the final keynote, we wanted to share a few items related to the presentation. We won't be able to answer questions live during the event due to time restraints. However, if you have any questions throughout the presentation, please submit them in the Q&A box on the right-hand side of your screen on our stage. After the presentation, we will compile all the questions and send the answers in a post-event email. Keep in mind that we won't be able to answer questions about individual diagnoses or treatment plans, and we encourage you to use the information you learned today to have conversations with your care team. Additionally, for the first time ever, we are offering small group discussions at ResearchCon directly after this keynote from 9 to 10 p.m. Eastern Time. These offer an opportunity for attendees to connect and share experiences with their peers on the information and topics that we covered today.
That's right, Amy. We are offering small group discussions around living longer with CF, infections, CF-related diabetes, sleep challenges, activity and exercise, as well as a pop-up discussion on life without modulators in the Sessions tab on the left-hand side of your screen after this presentation. If you unfortunately experience any technology problems during the keynote, please visit the help desk icon on the left side of your screen. We also want to remind you that everyone in our community, that we do have our community guidelines, and this is to keep an open-minded and respectful venue where everybody's opinions and life experiences can be shared safely. We cannot give medical advice or specific advice about any person's specific diagnosis. If you need staff support at any time or want to report a violation, we also encourage you to visit the help desk. With that being said, I'd like to go ahead and introduce our closing keynote speakers. We'll begin with Dr. Victor Roggli, who's an adult with CF, but also a professor of pathology at Duke University Medical Center. We will then hear from Dr. Raksha Jain, who is a professor of pulmonary and critical care medicine and director of the adult CF program at the University of Texas Southwestern, where she also serves as the co-director of the TDN clinical research program. And finally, we will hear from Kristina, an adult with CF and clinical professional. With that being said, Victor, it's all yours.
Thank you very much, Jay. It's a great pleasure for me to be here today. As Jay indicated, I am a patient with cystic fibrosis. I'm 72 years old, born in 1951, and I'm a professor of pathology at Duke University Medical Center in Durham, North Carolina. Next slide. So I first really got sick when I was about 7 years of age. I grew up on a farm in the southern middle part of Tennessee, around a small town. And when I was 7, I was in the back garden actually, of my grandfather's house, hoeing the weeds out of the corn. About noontime, this is in a hot July day, noontime I came into the house and my mom had a horrified look on her face. She noted that I appeared to be pallid, that I appeared to be weak. I had these crystals on my shoulder. I was without a shirt. And she put me to bed immediately. The local doctor was called at that time. This is in 1957. The local doctor still made house calls. So the doctor came to my house, checked me out, gave me some shots of penicillin. And then for the next 5 years, I ate my parents out of house and home, gaining no weight whatsoever, and had a chronic cough. My parents, when I was 10, which had been in 1961, took me to an allergist in Chattanooga, Tennessee, who found that I was allergic, my skin testing, to just about everything. But he recommended to my hometown doctor the sweat test be done. And unfortunately, that was filed away into a folder never acted upon. So finally, in desperation, my parents took me in 1963 at age 12 to Vanderbilt University Medical Center in Nashville, Tennessee, where the physician who saw us there after just a short period of time recognized all my symptoms were classic for CF. although at that time he had not seen somebody who was 12 years old first presenting with CF. So they did a sweat test and confirmed the diagnosis. At the time that I was diagnosed, our family got a brochure about cystic fibrosis, which indicated that most patients with CF die before age 21. Nonetheless, I went ahead and went to school, went to high school, and then went to college. My grandmother had told me that I really needed to use my brain to make a living, so I went to Rice University in Houston, Texas. And after I completed that degree in 1973, I went to Baylor College of Medicine to get a medical degree in 1976. At that time, I was age 25, and after medical school, I read in the textbooks that most patients with cystic fibrosis did not live past 30 years of age. So I continued then with my training in pathology at Baylor-affiliated hospitals in Houston, Texas, where I completed that training in 1980 at the age of 29, and then came to Duke University Medical Center in Durham, North Carolina, where I've been located ever since. Next slide. So there have been, during my lifetime of 65 years of having been diagnosed with cystic fibrosis, there have been a number of treatments which we've seen evolve over time. And many of these treatments, and perhaps all of them, are related to research that was supported or funded by the Cystic Fibrosis Foundation. So one of the early things that happened in the 1960s is that enzyme supplements became available to help patients with CF absorb the nutrients better. So in 1963, I started taking those. I weighed 70 pounds in 1963, and after 2 years on the supplements, I doubled my weight to 140 pounds. In the 1980s, we began to have intravenous antibiotics available that would treat the Pseudomonas and other bacterial infections which were colonizing our respiratory tracts. And then the great discovery of the cystic fibrosis gene in 1989 from researchers in Toronto and in the United States. In the 2000s, we witnessed advances in transplantation, of lung transplantation in particular in patients with many lung diseases, including CF. And then in about 2010, we began to see inhaled antibiotics become available, like Toby, the inhaled version of tobramycin. And then finally, in the 2010s, the CFTR modulators, the cystic fibrosis transmembrane conductance regulator modulators, became available, with culminating in 2019 with Trikafta, which I myself have taken. So the next slide, as a result of these great advances, what we're seeing in the worldwide is an increase in the longevity in patients with cystic fibrosis. So this particular figure is taken from, it's shown in the lower right, the journal Chest, January of this year, volume 163, and the figure is actually on page 92. And what it shows on the left side is bar diagrams for many of the countries for which information is available about the average age of CF patients. The dark red bars are for individuals who are classified as adults, at least 18 years of age. And the pink bars, or lighter red bars, are individuals who are under 18. So what you can see is that many of the modern countries, such as the US and Canada at the top, that more than half of CF patients currently alive are adults, more than 18 years of age. The other thing is on the right-hand part of the graph shows how much money these countries spend per capita on health care. And one of the things that we can see is there's a direct relationship between longevity of patients with CF and the money that's spent per capita on health care. At the bottom, you can see countries that have very little spending on health care, and virtually all of the patients with CF in those countries are under 18 years of age. So next slide just summarizes what this graph shows. In most countries with available records, Most patients these days that have cystic fibrosis are adults, and that there's a strong correlation between the median age of individuals with cystic fibrosis and national healthcare expenditures. In other words, the money that is being spent on research, such as involving the CF Foundation, is clearly having a great effect on the lifespan of individuals with CF. So the next slide. I just want to touch briefly on the aging changes that are taking place with CF. Now at 72 years of age, I'm definitely experiencing these aging changes. To begin with, hair color changes. What can I say? I used to have brown hair, and since I was about a little over age 40, my hair has turned silvery. Another is at the upper right is cataracts. There are other eye issues that you can have with CF, as it turns out, but cataracts are involved, and particularly with CF patients, they tend to have peripheral cataracts. That is, the lens of the eye becomes opacified, and in its periphery of the lens, it doesn't affect your vision so much. It's a central cataracts that most people get with old age that don't have CF that affects vision. But as you get older, even the peripheral CF cataracts start moving more centrally and can affect vision. As a result of that, I've had cataract surgery with a lens removal for both of my eyes over time, and now I have intraocular lenses. Another thing that really has struck me, particularly in reading books such as the CF Warrior Project by Andy Littman, is the activity of many patients with cystic fibrosis, that they are some super athletes, runners, all sorts of sports activities that many patients with CF indulge in. And after you do that for a lifetime, you begin to get worn out joints. So I think one of the things we're definitely going to see with CF patients is an increase in degenerative joint disease. Osteoarthritis is the other name of it. Also, because of the metabolism of calcium, which is involved with cystic fibrosis, the bones can be less dense than normal with osteoporosis. So I think we're going to see a lot of joint and bone symptoms in CF patients as they get older. Renal issues, for myself, I can say that with IV antibiotics that I've had over the year, my renal function is not 100%. It's what I think they call mild to moderate renal insufficiency. It does not require dialysis, but it's almost certainly due to the IV antibiotics, which I had over the years to help fight the infections in my lungs. Another, cardiovascular, is going to be, I think, a big deal. The hearts and lungs work together, and I think we'll hear more about that in the next presentation. But cardiomyopathies can occur, and arrhythmias, abnormal heartbeats, can occur. I actually had abnormal heartbeat for about 4 years. It was uncontrolled and developed heart failure. And that was identified by a very astute clinician, treated, and now my heart's doing better. I was still being evaluated to possibly have an intracardiac defibrillator device implanted. But as I took Trikafta, my lung function got better, my heart function got better. My heart was saying, thank you very much, lungs, I needed that. As a result, my ejection fraction of my heart, my functioning of my heart improved to a degree that I no longer needed. I was no longer qualified for an ICD. And then the last issue, and we'll hear more about this too, are cancer issues as CF patients get older. One of the cancers that has been identified in CF patients is colon cancer. I myself had a colonoscopy just January this year. They found a good sized polyp in the very proximal part of my colon, right after the small intestine goes into the colon at that point. And they removed it, and it had some early changes of abnormal cells in it. It wasn't frankly cancer yet, but it was on its way. So that's something I think that CF patients are going to have to watch out for. And also for men with cystic fibrosis, aging is associated with prostate cancer in the general population. And I have just finished up radiation treatment last week for prostate cancer. So those are the points that I would like to make about my own disease and where aging is coming in. And I think that I would now like to introduce Dr. Raksha Jain, Professor and Director of the Adult CF Program at Southwestern in Dallas.
All right. Thank you, Victor, so much for sharing your story. And thank you all for joining us this evening. I know it's been a wonderful conference thus far, and I'm really excited to get to be part of this closing session. I'll just share with you, this is a disclosure from the CF Foundation. And these are my disclosures largely related to research work. So this, I think Victor has referred to this already, but it's a really nice depiction and a slide that was provided by the CF Foundation from a plenary session last year at the North American CF Conference, where you can just look at over time, the x-axis represents the last many years and the coming years, and the y-axis represents the number of people in the United States. And you can see in the purple that the number of children with CF has actually remained fairly steady over the last couple of decades and is projected to remain steady in the coming years. But when you look at this adult population that's represented in the blue, you can see that it used to be, as Victor said, that it was really CF was known to be an illness of children. But you look at now, which represents this yellow line here in the middle, when we're in the 2022, 2023 time period, that this has changed, that there are now more adults with CF than kids. And looking forward, the adult population is only going to grow. And the really great news about that is the reason the adult population is growing is because people are living longer lives, which is wonderful. And hence the reason we really wanted to spend the session talking about aging with CF. So I think it's important to realize that CF impacts nearly every organ in the body. And for many years, we focused largely on the pulmonary health and on GI health. And while those are still incredibly important, I think we have to recognize that some of the complications that we may have not focused on as much in the past may become more prevalent in the future. And I think there's a lot that we have to think about on what is to come. So one, will correction of CFTR by some of those who can take CFTR modulators, will that alter some of these complications? Will there be new ones that might come about? I think the opening ceremony already touched on mental health. I know that's one that's at the forefront of people's minds, but there may be some new complications to think about. But what I really want to highlight today is thinking about some of these complications in the context of aging and pointing out some of what we know, some of what we don't know, but at least some of the ongoing work that people are doing that are part of the CF community to try to help answer some of these questions. So this is just a depiction of kind of how, in my mind, I break down the multitude of considerations that someone has to think about while aging. And I've broken down adulthood really into two buckets, and this is very broad, but it's young adulthood and older adulthood, because they're very different in what I think is happening in someone's lives and things to think about. You look in that young adulthood time period, and depending on your health, of course, you're thinking about different things, but there's many who are balancing thinking about education and career planning, others family planning, and others just finding a routine with their health, their lung health, their diabetes management, weight control, mental health, etc. And as one ages, I think as Victor has touched on really nicely, there's a lot of additional things that not only impact someone from the general population, but I think really particularly may impact somebody with CF. And I think there's much that we have to learn about cancer screening, cardiovascular complications, menopause, bone health, and cognitive disorders. And there's many more, but I wanted to just touch on some of these and really, again, put them in the context of work being done and thinking about what you might have and tools that you may need as you go along your journey. But I think it's important to recognize that there's going to be a balance amongst these of what may be related to CF and what may not be related to CF. And then the other big piece that I think many of us as care providers, and I'm sure many of you at CF are wondering, which is, are my symptoms my age? Is what's happening to me just for my age, or is it CF? And I don't know if I'm going to have all the answers for you. In fact, I know I'm not going to have all the answers for you, but I'd like to touch on at least a little bit of what we know. So starting out, walking through that timeline a little bit on younger adulthood or early adulthood, And I think one big thing that I highly recommend you talk to your care teams about is when you're thinking about all this, how do you balance everything? How do you balance work and school, the stress involved of time, balancing finances, balancing your health, that they may have some ideas and things you can think about. For example, you can acquire about accommodations, whether it be on campuses that you're going to school at, whether it be through your human resources department, but there can be some accommodations made by being someone that has CF. Other things as you're thinking about what your career might be, think about, do you want a job that allows you some remote flexibility, or do you like the in-person scenario, and what's the best for your health? And it may be different for every person. Other things to factor in are there particular risks because of having CF? Are there exposures that you want to avoid, or are there certain environments that may not be good for you? Is there a setting, for example, if you have diabetes, that you may not have the opportunity to have nutritious snacks and take your insulin, and all those have to go into your thinking as you're planning for the future. And then importantly, inquire about the benefits as you're looking into jobs. Is this going to give you good medical insurance or the appropriate insurance? Do you have opportunities to have sick time? And finally, I think many of us know that I think there's plenty of people out there with CF that have disability. And I think as people have become healthier, which is wonderful, there are some concerns about, as my lung function goes up, as I'm in the hospital less, do I have a chance of losing my disability? And I definitely encourage you, talk to your care teams. Most of your care teams will have social workers that can at least help answer some of these. And if not, they might be able to provide you resources to lead you in the right direction to find out some of these answers. So I think another big topic that our younger adults tend to face and think about is family planning. And this can be a really wonderfully exciting topic. There's been an increased interest in expanding families by men and women with CF. And I think you can see in this figure on the right-hand side that's taken from the CF Foundation patient registry data that there has been a dramatic, in just these last 10 years, the number of pregnancies in women in the US has more than tripled in the last 10 years, which is thrilling. And why this is, I can't say that we know for sure. I think some of it is likely due to people feeling better and wanting to extend their families as they know they're living potentially longer and healthier lives. And I think some of this we believe to be potentially from improved fertility, that we know CFTR modulators are likely thinning cervical mucus secretions, and this can potentially help people who had challenges with fertility in the past. But with this, what you knew about your fertility may not be the same anymore if you happen to be on a modulator now. So talk to your teams. If you aren't interested in expanding your family or getting pregnant right now, think about talking to them about contraception and what might be safe for you. Other things you can talk to your team about, no matter what gender you are, is talking to a genetic counselor. If you have a partner, you may want that partner to have CF genetic testing done before you start planning expanding your family. And I think for men, we also recognize that majority of men with CF are not able to have children naturally. There's a lot of costs involved to assisted reproductive technology. We know it's a challenge because this is commonly not covered by insurance. And your team may have some resources for you to think about, or how to approach that, or what can you do to make this a little bit easier for you. I will direct you to the bottom. You'll see there's a couple of ongoing studies right now that are sponsored by the CF Foundation. One of these is called the Mayflower Study. It's a prospective study that is actually following women who become pregnant. It's currently enrolling, and it's looking at the impact of pregnancy on their health, whether they are or not on modulators. And additionally, and very exciting, it's also following their babies over time. I think many people have questions about what's the impact of my baby being exposed to modulator therapy, and it's going to follow these babies 2 years after birth to really understand that further. This other study, the HOPE CF study, another one sponsored by the foundation, is actually a broader study looking at the parenting in the context of being a parent with CF and how that can affect someone's health, the challenges they face, the impact on them, et cetera. So there's a lot of nice work happening in this space. I think another thing that I just wanted to direct your attention to, particularly for those who may not be familiar with it, is some of the CF care guidelines or checklists that are available at the CF Foundation website. I think historically this screening focused a lot on pulmonary and GI health. But you can see that over the years, this has really expanded to be a lot more all-encompassing, that now there are guidelines on flu vaccines, mental health screening, diabetes screening, DEXA screening, as Victor already pointed to, for bone health, colon cancer screening. And so if you're wondering whether you're up to date on these, you can always take these to your care teams. They may have their own checklist they use, but these guidelines have been evolving and are continuing to evolve. For example, there's an upcoming liver screening guideline that's about to be published by the CF Foundation. So I think people are well aware that everyone's manifestations of their CF may be different. And I think over time, we're really hoping to tackle many of these topics that may have not been at the forefront of people's minds in the past. So moving a little bit into this more older adulthood category that I think Victor really touched on very nicely, I think there's a few topics that I just wanted to highlight. And I think he already mentioned that even in the general population, cancer becomes more prevalent as you become an adult. And there's a lot of questions we don't know yet, and some really unique risks that you have to think about. And I put these in a couple buckets where there's a number of cancers out there that your family history can direct in terms of what your screening is that's necessary, or risks that are necessary that may or may not be related to CF in any way. For example, I think the two classic of these is breast and colon cancer that can run in family. They can have families. They can have very unique genetics. And those are the kinds of things that having either your care team involved, a primary care physician involved, or specialists that can help guide you on that are really, really important. There's other unique risk factors that can be out there, including having had an organ transplant, where an organ transplant can often put someone at risk or higher risk for certain types of cancers, one of those being colon cancer and another being skin cancer, which we often don't talk about. But I think one that, I think Victor very nicely pointed to was colon cancer screening. And I think the reason this has been probably more looked at and more dealt with in depth from the CF community is that we really know that there is a 5 to 10 times higher risk of colon cancer in somebody with CF who's not had an organ transplant, and that risk increases even more in somebody who's undergone an organ transplant. So colon cancer is critical, and there are some very nice guidelines available and published by the CF Foundation that already recommends that someone should receive colon cancer screening earlier than the general population. And your unique risks may even change that further. But I highly recommend, talk to your care teams if you have concerns about that. And there's some other really important things that they can help you with, including unique preps that may help you clean out better for a colonoscopy. There's, again, some nice work happening in this space. Christine Hashem is running a study sponsored by the CF Foundation called the NICE study, where she is actually looking at a number, or at least a different type of stool non-invasive test, and comparing whether this non-invasive screening for colon cancer can be comparable to that of a colonoscopy. This is ongoing, so we don't know the results yet, but your care center may be participating in this study. So if you're interested, please reach out to them. But you look at other areas of screening out there for the general population, including mammograms, pap smears, prostate exams, and we really don't yet know, should that be different for someone with CF? Are there unique risks? I think we'll have to learn this over time, but we don't know yet. And so pairing your care with your CF care team and sometimes with primary care doctors can really help make sure that you're getting, I think, the best answers you can to some of these questions we don't know yet. So then moving a little bit into cardiovascular complications, I think this is, again, another topic that as people age, the heart becomes a more important organ to think about. Historically, I think in CF, pulmonary hypertension had been something we were aware of. Pulmonary hypertension is when you have high pressures in the vessels of the lung, a form of high blood pressure, you could say, in the lungs, and that can distinctly affect the right side of your heart and cause a real strain on that right side, leading to failure of that right side of the heart. What we haven't really learned as much about is the traditional heart disease of coronary artery disease or vascular disease that can cause other aspects of heart disease. There's a really nice publication that you can see a reference out here of a review article that was published just earlier this year in the Journal of Cystic Fibrosis that goes into some of the possible contributors within CF that may impact the cardiovascular system that we don't know. We do know that the CFTR gene is expressed in the cells that line vessels and in many of the heart cells, but how that translates into anything related to heart disease, we have much to learn. And we do know already in the general population, things like diabetes, weight management, lipid or cholesterol control, family history, blood pressure control become important. And you may struggle with some of these things, whether they're related to your CF or not related to your CF. So I think, again, talking to your team, asking them whether you should see a cardiologist or get screening tests, involve them, because I think this is something we're learning about over time. I think then getting into another area that I think tends to be a real struggle for some of our women in particular is menopause. The definition of menopause really is not having a period for a 12-month period of time. And when this occurs in the general population tends to be between the ages of 45 and 55 years of age. In CF, however, it's entirely unknown. There's some ongoing work in this space to try to identify this better, but we really don't know. We don't know if things that in the past from steroid use, et cetera, could change these types of things. But what we do know is that the symptoms of menopause, many of which are depicted here, from sleep disturbances, hot flashes, difficulty concentrating, joint pains, things that have been classically linked to menopause, also overlap a lot with classic CF symptoms. And it can become very frustrating if you're reaching that perimenopausal time in life to try to sort out what is aging, what is menopause, what's my CF, and what do I do? There has been some literature out there in the general population that suggests that menopause can impact lung function in a negative way and be associated with a bit of decline in both FEV1 and FVC, which is vital capacity. But this in the context of CF has never been studied, nor has hormone replacement therapy. In general, people recommend using the lowest effective dose for the shortest possible period of time for your symptoms or your unique scenario. But how that hormone replacement therapy interacts with your CF, we really have very little literature on. But I hope in the coming years, this is something that we'll see as well work in. Then I know Victor touched on bone health as well. And this is something actually that guidelines were published by the CF Foundation over 15 years ago. And you can see the reference at the bottom of the page, but there are many unique risks to bone loss in the context of CF. You can see that steroid use, low testosterone, for example, low vitamins such as low vitamin D that you may struggle with, pancreatic insufficiency, general inflammation, all of these can affect your bone health. There are guidelines out there on screening that not just begin in adulthood, but actually can begin as young as 8 or 9 years of age, depending on other aspects of health. And these studies are done by the screening is done by an X-ray called a DEXA scan that looks at the density of the bones. Based on those results, it'll guide you and your care team as to the frequency of this. And the wonderful thing is there are now more and more therapies available to treat low bone density. And many of these therapies are often guided by endocrinologists, nephrologists, or unique experts within the endocrinology space called mineral metabolism doctors. And these unique medicines, again, have not necessarily been studied closely in the context of CF or much at all in the context of CF. But I think we will learn over time, can we use these same medicines? Are they going to work the same? But do inquire, because now I think, as Victor mentioned, getting older, you have to think about these things and protecting your bones and thinking about the long haul and what you can do to have sort of a preventative style to avoid those fractures or pains that we don't want people to have as they age with CF. And finally, I think this was so nicely touched on at the opening keynote of ResearchCon, but I didn't want to at least fail to mention that I think cognitive disorders really scare people as they age as well. We do know that CFTR is expressed in the central and peripheral nervous system. We know, in addition, when it comes to mental health, that there's a higher risk of anxiety and depression in people with CF as a whole. We know there's some increased risk factors with things such as diabetes and cognitive function, and we're learning more and more about an association between CFTR modulators and mental health. And there are many people now that have this at the forefront of their priorities when it comes to helping people with CF, understanding this, et cetera. But I would definitely, if you missed the opening keynote of ResearchCon, you can go back and watch that. And they really did a wonderful job talking about this. But I think we'll be learning a lot in the coming years about this space. So finally, I just wanted to end with this nice slide provided by the CF Foundation, which really shows you that with you at the center, I know many of you are well connected with your CF care teams, which we love. And over time, you really have to recognize that as you age, you're going to have to increase that circle or bubble of people taking care of you, because there's going to be a number of things that your CF care team may not have all of the expertise on. Many CF care teams are pairing with subspecialists, whether it be cardiologists, genetic counselors, gastroenterologists, et cetera, some that are within your CF care team and some that they are connecting with. But make sure that you don't feel shy in advocating for yourself and meeting other subspecialists, because with this whole team, I think you can get the best care. And I think you, along with us, are learning about this. And I think we're excited that people are aging with CF, but by no means do we have all the answers. But I'm excited to spend a little while with you this evening. And I'm going to pass it off to Kristina Robinson, who's going to share her story with us.
Thank you, Raksha, for your valuable insight that sheds light on the progress and future considerations of aging in CF. And Victor, thank you for sharing your lived experience about aging. Hearing your story inspires me because it demonstrates the power of your ambition. Hi, everyone. I'm Kristina Robinson, and in the next few minutes, I will share a 3 C's approach that has been instrumental in enhancing my quality of life, developing my knowledge of CF, and making a difference for the future. To provide context, I was diagnosed with CF days after my 40th birthday in 2015. I was in disbelief because of previous experiences with CF testing. In the late 80s, I had a sweat test with a borderline result. And when I was pregnant with my son in 2004, a blood test detected only one of my mutations. While many of my longstanding symptoms made sense in light of the now confirmed CF diagnosis, much of it didn't, because my cousin, diagnosed as an infant, was living in advanced stages of the disease at age 28. She died less than a year after I was diagnosed, and I experienced several challenging emotions like grief, denial, and guilt. These emotions seemed overwhelming, and it took time to sort through everything that I felt. And as part of the healing process, I thought it was important to share my story, hoping that my experience would help someone else. This led me to finding meaning and purpose in my CF diagnosis, and it later enabled me to develop my mission as a CF senior advocate. A link to my early story will be shared in the chat if you want to learn more. But getting to my 3 C's approach, which I think is valuable for all of us. We heard from Victor and we heard from Raksha a lot about connecting, communicating, and collaborating. And those are the 3 C's. So why these actions? As we get older, I think it's really important that we can continue to connect with others, especially peers. Connection for me reminds me that I'm not alone as I age, as struggles come up with CF, along with successes. I have a peer group to celebrate those milestones with. Connection provides comfort and support, along with inspiration. Communication is another important aspect. I think communicating, we heard both Raksha and Victor talk about working with your care team. And I think communicating is essential, whether you are sharing a story like I am today, or writing, advocating for yourself, or even for others. When you speak up, at least when I speak up, it offers insight to others about the design of what I want tomorrow to look like, or next month, or even next year, and in the years to come. With communication, and just a fun fact here, we as the CF community communicated so robustly last year at the topic of aging at ResearchCon through the survey. The feedback from that survey was the key driver in creating this keynote. So I want you all to know that our voice independently matters. Our voice as a community matters, and it makes a difference because the CF Foundation is listening. So be sure to complete this year's post-event survey. Now, the last C I want to talk about is collaboration. And I think it's really imperative that we collaborate as people with CF, with others, our peer groups, the foundation, and our care centers, along with other providers. I think collaboration is important because it helps to advance knowledge, not just our own knowledge, but others' knowledge of what we're going through. It also helps to identify opportunities and work to brainstorm and address problems. But collaborating is more than just working on something together. It's about establishing partnerships and enhancing existing ones and finding new ways to partner. So Raksha's last slide about incorporating other specialists into your care is really imperative, and it's important to collaborate with those providers and your care team. So how can you use the 3 C's? Well, first, as a quick ideas on the Get Involved page on cff.org, there's a list there. But there are other ways to get involved. Check with your care team about patient engagement opportunities. Many care centers have patient advisory councils or boards. They have newsletters, education days. They're working on quality improvement initiatives. There's the Cystic Fibrosis Learning Network, Therapeutics Development Network, all have patient champions providing direct feedback on projects. So again, as we age, I think it's important as new topics come up, as more information is discussed, it's important to get involved in those things. And there are likely other CF Center specific ways to get involved. So be sure to connect, communicate, and collaborate with your CF care team to find out how you might get involved in those activities. Another aspect is the CF Foundation chapter office in your area. Lots of ways to get involved there in raising awareness. Also with state and local advocacy efforts, speaking engagements, award nominations, fundraising activities, and outreach committee activities. The chapter executive director or outreach chair could help navigate some of those opportunities with you. So be sure to connect, communicate, and collaborate with them. The most important thing I think that I found in getting connected, collaborating, and communicating is becoming a member of Community Voice. Community Voice is the best way to get involved, stay informed, and participate in national CF community activities. So as a member of Community Voice, you receive early access to announcements about planning committees, advisory council, special projects, and surveys that impact research, care, programs, and improvements. And as we talk about aging, as the topic continues to develop and unfold, I think being a Community Voice member is extremely important because more information from us in the community can help to provide knowledge to researchers and providers that are working on our behalf on improvements. So it's free to sign up. It's available to anyone in the CF community. And for those friends with CF, if you are over 40, 50, 60, and beyond, becoming a member of Community Voice is especially important as we shape the future of what aging in CF looks like. So simply use the QR code or the link provided in the chat to sign up. New this year, right after this keynote, join Victor and I to connect in small group discussions. We will be sharing experiences about the topics that were covered today. I trust that you have gained valuable information and even heard something that motivates you during ResearchCon. Could it be one of those 3 C's? What are you inspired to do? Are you inspired to connect, communicate, or collaborate? The future is knocking, folks. What door will you open? Next up, Jay, Sigrid, and Amy will close us out. Thanks, everyone. Don't forget about the small group discussions after the closing remarks. Thanks.
What an incredible keynote. Thank you, everybody, Victor, Raksha, and Kristina, for your time and for sharing. Now we move on to the last agenda item for the 2023 ResearchCon. In the Sessions tab on the left-hand side of your screen, you can join one of 5 small group discussions around today's information topics: living longer with CF, CF-related diabetes, infections, sleep challenges, activity, exercise, and life without modulators. These are encouraged as a way to connect with others in the CF community and will not take on the format of information sessions.
Yeah, Amy, there are so many great resources related to the presentations you've heard across the last 2 days of ResearchCon and the resource documents found on the reception page. Feel free to spend some time exploring the resources and, most importantly, download anything you'd like to keep. Also, all the keynotes and information sessions from this event have been recorded and will be available in the replay tab, as well as the CF Foundation's own YouTube channel in just a few weeks.
Before you go, please take some time to fill out the satisfaction poll on the closing keynote under poll. It's on the right-hand side of your screen. Thank you all again for attending ResearchCon 2023. We look forward to seeing you in the small group discussions.